go ahead and start. Thank you very much, guys, for joining today. My name is Dr. Nimsing Ladab, consultant hepatologist. I'm welcoming you to this webinar on prevention of mother-to-child transmission of hepatitis B. This is relevant as it is quite a significant factor that may be foiling the transmission of hepatitis B, particularly in countries where it matters. I must say that I appreciate all of you who have taken time out of your restful Saturday to join at this webinar. I will allow you to just mute yourselves and unmute yourselves when the question time comes. I will try my best to be slow, deliberate, and clear. If there are any questions, please reserve it and ask. Unfortunately, I might not be able to see chats, so it's better to ask questions at the end rather than to put it in the chats. I might be able to put it on at some point. With that background, I will be starting straight on to sharing the screen so that you can see the slides which I'm going to be presenting. If any of you is seeing the slides, just indicate so I'm able to recognize that that is showing. Very good. Perfect. Right, so I'm going to be starting now. Prevention of mother-to-child transmission of hepatitis B. We shall look at the introduction in a background sense of the word. We shall also identify factors that are associated with increased risk of transmission, and then tailoring the management based on resources available in the country where you are staying. And then we shall display a little about the eligibility criteria and follow-up for those mothers who are possibly infected. Right, so hepatitis B infection is globally important. There's no doubt about that. As more than 2 billion persons have been exposed to it at some point in their lives. About 300 million persons are chronically infected by hepatitis B virus, that is worldwide, globally. Chronic means that infection lasting more than 6 months. Hepatitis B kills by causing fulminant hepatic failure, cirrhosis, and liver cancer. Okay, you can see a few of the slides there tell us things. The good news is that effective vaccine is available and which has shown effective decrease in the transmission of the virus as well as liver cancer. Research has been demonstrated by very large studies in Taiwan and some parts of Asia. For those already infected, effective antiviral agents are available. We do know that they're quite effective. They can suppress the viral replication and can decrease the incidence of cirrhosis and liver cancer. So there's no real doubt about whether a cure is there or not. It is almost what is used in defining medical cure. In other words, if there is no eradication, there is a near cure situation in this regard. We shall go on to introduction about the background of what we're dealing with today. There's a bad news, and there's a population, a remnant of population that can continue to transmit the infection to unborn babies if they are not targeted and provided treatment in a programmatic fashion. Many of you will agree with me that in many instances, you will go to hospital and adults are taken care of. Those children are vaccinated, but the mothers who are actually the ones that transmit the infection at a higher rate to their children are not targeted. And I think that is the importance of this presentation. Perinatal transmission of hepatitis B is known to fuel ongoing infection in developing countries of Africa and Asia. Okay, it's a goal of the WHO to eliminate hepatitis B by 2030. I'm afraid that that goal may not actually be realized if we do not do anything to actually target that population. So mother-to-child transmission of hepatitis B is one of the commonest modes of transmission of this deadly disease. Obviously, I don't aim to scare anyone by calling it deadly, because once it has killed a relative of yours, there's nothing non-deadly about it. So it's quite an important disease that needs to be sorted. We next look at the factors that are associated with increased risk of transmission. In other words, not every mother will transmit this disease to their babies. But there are factors in the mother that can actually increase that risk. Okay, there are 3 of them that are reported. If the viral load is greater than 200,000 units per mil, okay, that is a very serious high risk. If the child at birth is not vaccinated after delivery, okay, and or if there's absence of immunoglobulin, which is actually an antibody that would actually eliminate if any virus has entered into the child at delivery, okay? So not all of these factors are important. At least the first 2 are very important. The immunoglobulin is not very common and is not available in many developing countries. Now that is a problem, in which case, if you don't have it, do not be agitated. It is possible that with the first 2, targeting high viral load and the fact that the child is vaccinated against hepatitis B, you would be rather safe, better than not doing anything. All right, so we'll look at what are the tailored management that would be relevant in the country where you're staying. I am actually targeting mostly developing countries with this, but everything I will say here is applicable in the developed world as well. But I will bring out very important points that would be relevant to countries that are struggling with resources and which will be applicable to many people who are listening today. To ensure the risk of transmission is reduced, all mothers, okay, at antenatal clinic visit should be screened. All mothers, because in the country such as Gambia, where the hepatitis B surface antigen is about 15% or maybe up to 20% in some instances, it is very risky to allow mothers pass through the system without being screened. So you screen all mothers who are in highly endemic areas. If a mother is found to be positive, there are 3 tests, okay, that you do. Perform the viral load, okay, and then there's an E antigen, and then the liver chemistry, which is known as liver function test. Those 3 tests are very important in defining where to go on to next. If they are E positive, or there's an abnormal liver function, which is known as ALT, and or the viral load is greater than 200,000, then you start giving them antiviral agents from 28 weeks of pregnancy, that is during the last trimester. If a mother has a low DNA, that is confusing to many people. But if this was done within the first 13 weeks of pregnancy, then it is advised to repeat the viral load at 26 to 28 weeks, and then you treat as above. If it is low, still at that stage, then there is no significant benefit in giving antiviral agents. However, for very cautious people, it is still relevant to give the antiviral agents because it will still reduce transmission in a few cases. Mothers without evidence of hepatitis B infection or are exposed should be vaccinated because that would prevent if, for example, the father has it or there's someone in the family or in the environment, and particularly if the mothers are healthcare workers. Okay, that's important. We know that in some instances, and it's not very uncommon in developing countries, that mothers can come to deliver without having booked their pregnancy, okay? So when they come in, one of the initial quick tests you can perform is to do the hepatitis B surface antigen at the time of delivery, okay? And manage the baby, as I will advise later. Now, passive and active immunization, I mentioned this already. Hepatitis B immunoglobulin, which is the antibody against hepatitis B, and the vaccine should be given, okay, to the infant. That is a very important point. Tenofovir, which is the antiviral agent, has been considered to be safe in pregnancy relative to other agents. So lamivudine and all those ones are not as safe as tenofovir. So that is the medication that should be given to mothers from the last trimester till delivery and afterwards. Now, this slide actually gives a summary of what is involved. I will explain a few in the following slides. It's busy at the moment, and don't be afraid to go through everything or be agitated that it's too plenty. I will be sending these slides to those of you who want to have it, and that way you are able to go through at your own time and at your own pace. Important here to note is vaccinate, okay? Administer hepatitis B dose vaccine to babies born in high endemic area of Africa. Next, when they come for pregnancy booking, screen all pregnant mothers. If you have to give the immunoglobulins, it is best within 72 hours. However, in resources where you need to import this, it might be better within 14 days. If this is too expensive, research has demonstrated that given the vaccine there is no escape from it. You need the vaccine rather than the immunoglobulin. Now, all positive mothers should start Tenofovir from 28 weeks of pregnancy. And if they are positive, and if they are negative, vaccinate them. Remember that if they cannot do the hepatitis B viral DNA, which is a viral load, you can use the E antigen as evidence that the virus is multiplying. If that is positive, you can go ahead and give them the Tenofovir without them passing to doing the HBV DNA. This is very important for many countries that do not have facilities to do HBV DNA. Right. So what are we saying? Pregnant mother, offer test to them at booking for pregnancy. If they are negative, they take a pathway. If they're positive, you go on to the next pathway, and which is do a viral DNA or E antigen or both, okay? Check for whether or not they already have pre-existing damage to their livers by doing ultrasound and imaging. Right, so we go into the algorithms again to be specific. There are 3 scenarios here. Pay attention to this slide. I think this is the high point of what I will be saying. So the investigation that you do, the action for mother and action for baby. So the 3 are important. What investigation do you do? Now for the mother, the investigation that you've done is HBV DNA. If it is less than 200,000 or they are negative to E antigen without cirrhosis, you do not need to give Tenofovir, okay? Long-term Tenofovir may be delayed, but you need to monitor that mother and reassess, okay? That's what the WHO says we should do. This is very important for resource-poor limited settings. For the baby, whether the mother was given anything or not, as far as they are positive, you go and vaccinate the baby with the hepatitis B vaccine. Now, the second scenario is the viral load is greater than 200,000, or in other words, one can replace the other. E antigen is positive without cirrhosis, whether the liver is damaged or not. You give them treatment. Okay, start Tenofovir, reassess for long-term maternal Tenofovir treatment, and after delivery, and monitor them. So you don't discard the mother once they have given birth to baby. The mother needs to be followed up as well. But the child will need to be vaccinated. In all scenarios, vaccination for the baby, known as birth dose vaccine, must be given. Now, if at the assessment, the mother was already having cirrhosis, in other words, the liver has become scarred and fibrotic and hard, in other words, damage has occurred, or the DNA is higher than 200,000, and there is abnormal liver function test, what do? You start long-term treatment, okay, and monitor. This is going to be for life for the mother, and that baby should be vaccinated. What are we saying? Birth dose vaccine, there is no escape from it. It must be given, and you complete the rest of series for the baby, okay? If you have the immunoglobulin for infants born to hepatitis B first antigen mothers, you give them. But if you don't have, do not be afraid. The birth dose vaccine is good enough. Okay. Now, women who start tenofovir during pregnancy for the purpose of preventing mother-to-child transmission may stop immediately after delivery. That is what the WHO provides for us. Stopping is particularly necessary if they want to breastfeed, because, of course, we know that medication can go in the breast milk as well. And if a baby does not need to get onto it, there's no need to actually be going on the tab on the medications. Some liver specialists, together with obstetricians, may prefer to continue treatment for about 12 weeks after delivery, in which case the mother may need to use formula feed. The liver enzyme should be monitored every 3 to 4 months if the baseline was abnormal. So that is important. It is not uncommon to have liver function remaining deranged when you are on treatment, but it will settle. Those are all mechanisms that delay and or may be confusing for some people. Now, if the mother was already deemed to have need for treatment as per adult, in other words, non-pregnant people, then the treatment does not need to stop. It should be continued, and the patient should be put on the pool of follow-up by liver specialists. We're almost done. Hepatitis B transmission is not common when the mother breastfeeds her baby, especially if the baby received the birth dose vaccine and completed the series. If there is suspected nipple injury or risk of bleeding from the breast, then formula feed should be recommended. In other words, breastfeeding is good. It is okay if the mother was positive to hepatitis B, but the child should have been vaccinated. Okay. Now, what do you do in the absence of immunoglobulin? If there is unavailability, then go ahead with hepatitis B vaccine. This is very important and cannot be omitted. That will protect your baby and make you happier at the end. In summary, hepatitis B transmission in mothers is not an uncommon event, okay? The problem is most felt in developing countries with resultant cirrhosis and liver cancer, okay? Most common route of transmission of hepatitis B in developing countries is mother to child. We call that vertical transmission. Effective treatments and vaccination against hepatitis B are available. We do know that. But prevention of mother-to-child transmission requires a lot of efforts. And I think that is the missing link that will actually help in eliminating hepatitis B virus in circulation within endemic regions. Targeted interventions will be required if elimination of hepatitis B virus is to be achieved by 2030. I've got some apps for you, hepatitis B in pregnancy, which of course could be downloaded from Google Play Store, Liver Health app, and so on. So this concludes the description of what we intend to do today. But I will give time for us to interact and ask questions. So in order to make this a well-coordinated effort, you could unmute yourself and then we will wait and hear you. Be as clear as possible, avoid background noise, and we will be able to assist as much as possible. There are other specialists who have joined since we started this webinar, and they will be able to also contribute where I cannot answer questions clearly. But be patient with us and let us enjoy this part. There are courses going to come in block forms. In other words, in a weekend, we will do about 5 or so topics and make ready downloadable materials for your own learning, as well as certificate courses. Look forward to this. And as many of you as have actually sent in or booked this, I will have your emails and we'll be able to send you updates as well as the materials you need to download. Let's unmute ourselves for questions now. Brilliant, thank you guys. Welcoming questions now. Right, it seems Dora is ready for questions, or maybe a contribution, a word or two is fine.
Okay, I wanted to ask if the vaccination schedule is the same for children as in adults. The first one at birth, and then 1 month later the second dose, and then six months later the third dose. Is that how it goes for babies?
Yes, so the way they do it for babies is that they actually integrate it to the National Program on Immunizations, so that as you take the baby, you just get the vaccine as well at the same time. So it's if you're busy and cannot do it differently, then finishing it within 6-month period is fine. But it's better to go to the National Program on Immunizations. Most places will give 3 doses, as you alluded to. Okay. Right, my friend. That's Lucy. You want to say something? Or no, it's not Lucy. Sorry, there's another person who was unmuting. So I didn't see your name. I just put techno pop to power. So if you have, I mean, if you had your name, I would have called it. Sorry if I don't call a name. Guys, brilliant. So it seems that we don't have much questions coming from your end. Or you're very shy to ask questions. All right, if you feel it's easier for you to type the question, I will wait for you to see whether there's any question being typed, and I will answer you. Now, can I ask anyone, perhaps somebody, let me see who is, Happiness, are you there? Can you unmute yourself, please? And let me ask you a few questions. Very good. Happiness, would you mind tell us a little about the experience of a mother when they go to the hospital for antenatal booking, if you know any? What happens? Maybe challenging internet there. Okay, very good.
Yeah, when I get, yes.
We can hear you now.
Okay, vaccination. I breastfeed my baby for like a year plus. There's no, there is nothing like there's nothing like you will not breastfeed your baby because you have hepatitis B. I was diagnosed with hepatitis B for some time, but after giving birth, I was not stopped. The doctor advised I should breastfeed my baby very well, because the children will be vaccinated, the child will be vaccinated. So they collect their vaccine in time. I think before breastfeeding, they gave them vaccine at birth.
Yes.
That's my experience.
I think that's very good. I mean, this is because you're well informed. And so did you have to ask for that vaccine, or somebody offered it to the child? Or did they plan it when you were, was it a planned vaccination, or did you read about it and demanded it, or was there somebody telling you to offer it?
No, it was on my file that I was hepatitis. So the doctor knows that there is a need for the kids, for the baby to be vaccinated because of the transmission from the mother to the child. So the child was given the vaccine in time.
Very good. I think that's commendable. At least there is hope if that was well arranged in advance for you to have. That's very good. Thank you very much for your experience, sharing your experience.
Okay.
Right. Roji, have you got comments?
Morning, sir.
Morning.
Exactly.
Morning.
Are you Are you getting me, sir?
Oh, yes. So initially, I didn't get you. Say the comment again.
In case of, there are some villages, I don't know, like when mothers are being diagnosed with that hepatitis, even that they give them at home, because some don't care to be attending antenatal. Unfortunately, at the end, they will give birth at home. And if the mothers are positive of that hepatitis, any means or any way that the child will be prevented from infected.
Thank you very much for that. It's a very real scenario situation there. I will believe that unless they have been tested, there's no way we would know that the mothers are positive. But if eventually it is known, the earlier the vaccination, the better for them. It is assumed that if a child was born within an endemic region, such as Nigeria is one of those places, then the child should actually be vaccinated against hepatitis B, whether or not the mother was infected. So that's very important. You offer the vaccine at the earliest vaccination attendance that the mother takes the baby to. Hepatitis B should be part of that. I think that would be the way forward with it.
Madam, good morning.
Good morning.
How are you? I'm
brilliant. Who is it?
Sorry, I joined in late, but I'm Amina Mohammed.
Oh, perfect. Thank you very much, Amina. Brilliant. Go on.
How are you?
I'm fine. Thank you very much, Dr. Mohammed.
Welcome. I'm your classmate, actually. I don't know if you remember me.
Very well, Amina.
Okay.
Yeah.
So just to say thank you for this presentation, although I joined in late, but Nigeria is already on the path because the immunization schedule, the new immunization schedule have hepatitis B as early as 6 weeks, 0 hepatitis B 0,
yeah.
And then the weeks, rhyming with the polio vaccination.
Yes.
Which is also a plus because I heard you were saying that it's good to have it early. So just to mention that Nigeria is already, rolling out such immunization services, scheduling in their family health clinic.
Thank you, Dr. Amina Mohammed. That's brilliant because clearly, like Rochi, one of the participants mentioned, the big challenge would be those mothers who never attended the antenatal in the first instance, and then they come to vaccination. What do you do? So I think it's a good thing that the Nigerian government has that mechanism in place, and in which case vaccinating them at the first attendance, including hepatitis B, and going alongside with the national program on immunization would be the best approach. And I think it's commendable. Thank you very much for that. Those comments, Amina. I'm very proud you attended and supported this presentation. Right.
Good morning.
Got about 7 minutes. Oh yes, Godson, go ahead.
Good morning, sir, and everyone in the platform. Yes. I have a question in regards to a pregnant woman. Is it possible for hepatitis B to be transmitted to an unborn child, from the mother to an unborn child? And if it is possible, what is the way forward to preventing mother to child to an unborn child transmission of hepatitis B?
Right. So brilliant. Thank you very much, Godson. Clearly, these are the issues we've been discussing, and the certainty of and the cream of everything we've said today is about preventing the transmission of the hepatitis B from mother to child. We mentioned 3 factors. And of course, transmission is real one. We need to get the mother to know whether they are actually at high risk or not. That is in the hospital itself. But apart from that, there is a national program ongoing, like Dr. Mohammed mentioned, and it's clear we know that there's vaccination in place, which should be started on the day the child was born, and to complete it with the rest of the national program on immunization schedule. The other bit is if they have the immunoglobulin, which is very expensive, you can administer that as well at the time the child is delivered. Those have a very high chance of preventing that transmission risk. Okay.
Okay.
I hope I answered the question, Godson.
Not too clear, sir. I want to know if it can be transmitted from the mother to an unborn child. That is the child.
You mean whether that transmission has occurred even before a child is born?
Yes, sir.
Yes,
it possible
it is possible. It is very possible. And so we only try to catch those ones that actually may not have had the transmission, so we prevent it. Okay. So there are chances, but it is limited when we do that.
Okay. So if it is possible to be transmitted that way, what can we do to prevent that transmission from mother to an unborn child?
That is the subject of high research, but luckily it's a very rare scenario actually. So there's not much that can be done when it has happened. For example, if transmission happened before the interventions we mentioned, but those are very rare.
Okay, thank you so much, sir.
Thank you. Peter Yakubu is asking a question here. What is the implication of suspending the antiviral drug during the breastfeeding? Very, very smart question. Now, research shows that transmission is very low at that rate, at that stage of the delivery, and if interventions had taken place before the child was delivered. And so we think that that risk is really very low at that point. That's why the research outcome recommends that if it is possible, the mother should stop the antiviral medications. But for mothers who actually have cirrhosis and or viral loads are very high, or evidence that they need long-term treatment, then it is better to continue the treatment without stopping it, and getting the mothers to then, vaccinating the child, mothers continue their medication, and possibly the child may get formula feeding, although risk benefit will actually tell you to breastfeed the mother, breastfeed the child. Yeah. Sorry for mumbling there, but I hope you understood that. Yeah. We got 3 minutes to go, so we can take 1 or 2 questions and be gone for the day. But remember, if you registered, you are going to be receiving the slides via your email, or I'll direct you in an email on where to find the slides in a PDF form, and you can download it.
Frank? Hello?
Hello, Lucy, go ahead.
Yes. Yeah, thank you so much, sir. This has been great. I would really want to find out if cesarean section really provides any benefit against transmission than vaginal delivery.
Brilliant question there, Lucy. So far, at the moment, there has been no additional benefits that cesarean section provides. I know that is one that was advocated for HIV at some point, but not for hepatitis B. Yeah, so there's no research to demonstrate that it reduces transmission risk. The 2 interventions that we mentioned are antiviral agents and vaccination and or immunoglobulins. Right, very good question. Yes, go ahead. What, 2 minutes left?
Okay. Sorry, I want to know if hepatitis B can cause in between menstrual bleeding in a woman.
That is a very smart question there. Thank you very much, Happiness, again for that. What I would say is that the hepatitis B on itself cannot cause bleeding. Okay, if over time it actually has progressed to forming cirrhosis, and then there is impact on cells such that the platelets, the coagulating blood cells are abnormal, then bleeding control of bleeding is limited. And so if there's liver damage, then that happens. But if there's liver damage, if there's no liver damage and you're having those kind of bleeding, then investigation for alternative causes will be relevant. So that's what I will let you know. But it on itself does not cause bleeding. Right, I think we're done. 1 minute left, and there's not much time to actually ask a question and answer one. And I don't want anyone to, but if you have any further follow-up questions, just send them through on the email that you got when you registered. And also there will be links as well that will be available, and also subsequent programs on lectures that may be relevant to you. Follow us, become members on the website, and I'm sure you will be kept abreast with more lectures. I can see a question here from Hilton John. Doing a great, okay, that was just a comment. A great job. Thank you very much. Thank you, Hilton, for that suggestion. Thank you. All right, guys. Thank you very much. Have a blessed Saturday, and enjoy yourselves. And I'm happy to continue to collaborate with you guys. I will keep coming on